Entonces, nuevamente con la doctora Beno, a quien ya había presentado como profesora de la Universidad de Toronto y especialista en medicina de emergencias pediátricas y en trauma pediátrico, ahora a dar una conferencia que se llama Nuevas tendencias de transfusiones en trauma pediátrico. Así que bienvenida nuevamente, doctora Beno.
Hello again. So we're going to go ahead and speak a little bit about transfusion strategies in pediatric trauma now. Again, I have no conflicts of interest to declare and assume responsibility for the accuracy and scientific validity of this presentation. So this time, the learning objectives are threefold. We want to talk a little bit about the epidemiology and the unique physiology of children with respect to hemorrhagic shock, and also to review the evidence that's available and how that applies to transfusion strategies in children to optimize outcomes. And where we can, we'll highlight emerging research and critical areas that are in need of further information. Trauma, as we know, is the leading cause of mortality in children and adolescents. And while traumatic brain injury is the leading cause of that, hemorrhage is the leading preventable cause of death after injury. And United States statistics show that probably 1,000 to 2,000 children every year die from hemorrhagic shock because of delayed or inadequate care. And so I think it's very, very important to realize that the 30-day mortality in children with life-threatening bleeding is 36 to 50%. When you compare that with adults, so it's 20 to 25%. And this becomes a particularly topical and relevant concern when we realize that epidemiology is shifting. In Canada, we see primarily blunt trauma in pediatrics, although we have started to see more penetrating. In 2019, it was very sobering in the United States that firearm-related injuries surpassed motor vehicle collisions as a leading cause of mortality in children and youth. And I believe you likely have some penetrating trauma here in Colombia as well, and so we're very likely to encounter hemorrhagic shock both in a blunt and a penetrating pediatric trauma patient. So I'll start with the case again. So here's a little 3-year-old boy who was walking with his mom on the sidewalk, and he let go of her hand, and he ran out into the street, and he's struck by a vehicle. That vehicle happens to be a truck. It's a slow-moving vehicle. It's only going 30 kilometers an hour, but this is a small child, and he's caught under the rear tire and dragged about 10 to 20 feet or so. So on scene, when the paramedics get there, he's crying, and he's actually verbalizing that he's thirsty. He has shallow breathing, his heart rate is fast at 160, his blood pressure is 90, and he has abrasions, significant abrasions to his chest and abdomen. What the paramedics do is they put him on oxygen, they put him in spinal motion restriction, they start a peripheral IV, and they start a 20 ml per kilo normal saline bolus. Pretty standard management. By the time he's in the hospital, he has deteriorated. He's a very sick, injured patient now. He required an airway, he's being mechanically ventilated, his vitals are abnormal, and he's very cold. So hemodynamically unstable trauma, hemorrhagic shock, specifically in a small child, should make everyone uncomfortable. This is a very high-risk clinical situation. And some of the questions you might have include, do damage control principles apply to children? Is tranexamic acid indicated? If so, what dose? If I don't have blood immediately available, can I give crystalloid? How much blood should I give? When should I activate my massive hemorrhage protocol? Do we have a massive hemorrhage protocol? And should I consider permissive hypotension? And maybe one of the most important questions is, what do I need to do for this patient if I don't have a pediatric surgeon? It's a very complicated topic with a lot of literature and a lot of things to discuss. So in my brain, as an emergency physician, I like to keep things fairly simple. So we're going to put these into 4 buckets. Bleeding, the approach to bleeding, early and rapid hemorrhage control. Turn off the tap as fast as you can. Identify shock, Recognize life-threatening bleeding in those early phases, which can be quite subtle in children, and so it takes some clinical skill to be able to pick that up. Also recognize that what they've lost needs to be replaced, and so that's considered a balanced resuscitation, and that should be done using damage control resuscitation principles. We'll talk more about that. And then ultimately, it's definitive source control, getting them somewhere where it needs to be absolutely stopped in the operating room, the interventional radiology suite, what have you. Where do people bleed from? So the ATLS, or the Advanced Trauma Life Support course, teaches you floor plus 4. So if you don't see the blood, it's not on the stretcher, it's not on the floor, it's not coming from the back of the head, what have you, think about the compartments of the body: the chest, the abdomen, the pelvis retroperitoneum, or long bones. Now, caveats to young children is that long bones, like femur fractures, where in an adult you can lose a significant volume of blood, young children who are skeletally immature, thick periosteums and what have you, we tend not to see that. They tend not to lose that much blood in the long bones, and so if you do see that and you have a child who has hemorrhagic shock, I caution you to fixate on the long bone fracture, but please think elsewhere. Where else is this child bleeding? The other thing is infants are unique. They have large heads, they have soft skulls, they have fontanelles, they have suture lines. We cannot lose much blood into our head. A child or an infant absolutely can. So please consider the head in a young infant. So thinking about some pearls, a child's blood volume is higher proportionally as the younger that they get. So on average, it's about 80 to 90 cc's per kilo. And the smaller the child, you can see that it doesn't actually take that much blood to actually be a significant amount of blood loss. In adding to that, a child may lose up to 35 to 45% of their total blood volume before they become hypotensive. In a prospective observational trial that was done, the first that was done, looking at massive hemorrhage for surgical bleeding, trauma bleeding, operative bleeding, 60% of children presented hypotensive. That means, and these are patients who required massive transfusion. Only 60%, so 40% did not have hypotension, had normal blood pressures on arrival. It becomes very, very important, therefore, to look at those other signs of perfusion and beware persistent tachycardia. Children who are persistently tachycardic are talking to you. They're telling you something is wrong. It might be anxiety, it might be pain, fear, what have you. It'll get there. But if they are persistently tachycardic, you must think, just like you think sepsis in a neonate with fever, you must think hemorrhage in a traumatic patient with persistent tachycardia. And you have to assess those secondary signs of perfusion: capillary refill, skin temperature, color, to not miss early compensated shock, which is where you want to pick it up if they have it. The most common source of blood loss in a child is the abdomen. And think of the chest and the abdomen as a single entity. Because their chest walls are so pliant and so forth, if they have chest trauma, they likely have abdominal trauma. If they have abdominal trauma, they likely have chest trauma. And the talk is focused on transfusion strategies, but thankfully, less than 5% of children who present to a pediatric trauma center actually need massive transfusion, and it is the minority of children who have uncontrolled hemorrhage. But the stakes are very high, and that's why we need to always talk about it. So, crystalloid, salt water. There was, a big shift. As things do in medicine, the pendulum often shifts back and forth. So after the Vietnam War, we started pouring crystalloid into trauma patients, 2 liters here in the field, 20 mils per kilo, 20 mils per kilo, 20 mils per kilo, and then moved to blood in a child. And it has now, for some time, been recognized that that is a harmful way to approach fluid resuscitation in trauma patients of all ages, including children. So if they need fluid, the idea is that they should be given blood to achieve a perfusing blood pressure. But it's a little bit more complicated than that. So when I think about the fluid strategy for pediatric trauma, I lump it into 2 categories: the children who present in compensated shock and the children who present decompensated, who are critically actively bleeding or hypotensive. We are going to spend most of our time seeing patients in this category because most children are bleeding because they have a solid organ injury. Most children have very robust compensatory mechanisms where they vasoconstrict and are able to stop bleeding themselves. Less than 5% of children with solid organ injuries actually have a laparotomy. So if we approach these children with any abnormal perfusion by giving them blood, we'd be vastly over-transfusing this group. So it is appropriate to use crystalloid in this group. And a 20 ml per kilo bolus is fine. And that's in fact what the Advanced Trauma Life Support course teaches you. But we actually have prospective research now demonstrating that after 20 mL per kilo in a child who has a positive shock index, so a child who has ongoing signs of hemorrhagic shock, additional crystalloid after that is simply going to keep them on a ventilator longer and keep them in an intensive care unit longer because of all of the fluid overload that they have. So after 20 mL per kilo of crystalloid, you move to blood. And that blood can be given as 5 mL per kilo aliquots to sort of reduce your chances of popping the clot, so to speak, or it can be given as 10 mL per kilo or 20 mL per kilo. But 20 mL per kilo, if you still need to give blood after that child, you should be thinking about activating your massive hemorrhage protocol. In a patient who presents critically unwell, active bleeding, hypotensive, that's not a patient who benefits from crystalloid in any way. You should move directly to blood products. Maybe that's starting with red cells, maybe that's starting with your massive hemorrhage protocol. Massive hemorrhage protocols or massive transfusion protocols, and I'll talk about the difference, come in all shapes and sizes. There is no right one. They're all, you would think for something that, that we would have one standardized protocol. Every institution has a different one. And in pediatrics, they haven't actually robustly been shown to reduce mortality, unlike in adults where they have. But they organize care, they efficiently deliver products, and they are a better approach. They're safe and really should be standard for massively bleeding patients. So the important thing here is, I think, to not focus exactly on the logistics of your protocol, but get to know your protocol and practice your protocol so that you understand what you have access to and what products are going to come and what are the steps you need to take in order to make that happen. Here's a nice example of a massive transfusion protocol. So for anybody who's using, for example, a Broslow-based transfusion guide, this is very, very helpful for community providers who are using Broslow tapes to look after children when mostly they're looking after adults. This is a nice protocol. It was put together through a Delphi consensus through the TikTok trial, which was a feasibility study for utilizing tranexamic acid in trauma. And it's weight-based, and it uses empiric ratio-based, so 20 mL per kilo of red cells, 10 mL per kilo of frozen plasma, and 5 mL per kilo of platelets. Very nice, massive transfusion protocol to use. Here's an example of a massive hemorrhage protocol. We have surveyed nationally in Canada and provincially in Ontario, and only 30% of centers actually had a massive hemorrhage protocol for children, or some sort of MTP or MHP for children. So in 2019, we started working on standardized protocols that could be used as templates for hospitals within the province who didn't have that, who didn't have a protocol already to use. So we have adult and pediatric protocols for both large academic settings and community hospitals where they may not have access to plasma or to platelets. And so you see some options here. The difference between the massive transfusion protocol, which is basically what you're transfusing, the massive hemorrhage protocol is a very prescriptive protocol that details all of the damage control resuscitation principles within that. So it talks about your temperature, it talks about your calcium, it talks about a lot of different things that are included within that massive hemorrhage protocol. So here's an example of the pediatric ones. These are sort of the typical cooler sequences that they've come up with. Again, this is not the perfect or right protocol, but it is a protocol and a template that allows institutions to develop something that they can use. We talked a little bit about resources like TREC and the National Pediatric Readiness Project. The other resource that I want to share with you is the Transfusion Ontario Toolkit for Massive Hemorrhage. And so there is a very large comprehensive toolkit for an approach to a bleeding trauma patient, and there's a pediatric toolkit as well. And that's full of lots of helpful tips and tricks, I think, that anybody can use. So when we think about damage control resuscitation, we know who we're applying that to is the children who do have life-threatening bleeding, who are at risk of traumatic coagulopathy. These are children who, potentially have coagulopathy already before they come to you. So it's not dilutional coagulopathy from crystalloids, it's coagulopathy from intrinsic tissue damage. In adults, that's about 25% of trauma patients. In children, that ranges from anywhere between 10 and 77%, all over the map. And so there's a number of hemostatic issues that go on after tissue injury that can lead to problems. So the damage control resuscitation principles are hemostasis, both mechanical and pharmacological, minimizing crystalloid, providing a balanced transfusion, hypotensive resuscitation, correcting coagulopathy, acidosis, and hypocalcemia, maintaining normothermia, and expeditious source control. So again, if this patient is in your emergency department, what are some of the things that you can do immediately to help them? So one of the first things is hemostasis. So it's that early hemorrhage control. Rapidly turn off the tap. So if you can apply direct pressure, compression bandages, hemostatic gauze, if it's an extremity hemorrhage, using a tourniquet, validated in children. If it's a pelvic fracture, putting on a pelvic binder. Very careful when you put these pelvic binders on that they're low riding. They shouldn't be up at the waist. The most common problem with pelvic binders is that they're up at the hips and not at the trochanters, and they don't work that way. So in order to close the pelvis, you need to keep it low. That's mechanical hemostasis, or what is known as stop the bleed, and taught in a stop the bleed course, for example. Pharmacological hemostasis is the use of antifibrinolytics, of which tranexamic acid in trauma is the one that's favored. Permissive hypotension. So I'm not sure if everybody knows what that is. It's a little bit of a controversial talk. Again, a lot of the trauma approaches to hemorrhage control have been extrapolated from combat or military settings where they have shown it to make a survival difference. And permissive hypotension is that trade-off between adequate perfusion and hemostasis with a quick route to the operating room or a quick route to IR where you're going to stop the bleed with a definitive source control. It is a trade-off, and in adults it's used fairly routinely. It is not used for anybody who has a traumatic brain injury, because as we know, you need a certain cerebral perfusion pressure in order to optimize outcomes with a traumatic brain injury, so it's not appropriate in those populations. It's also not endorsed for children. It's not endorsed at all for pediatrics, even from a 2023 shock consensus hemorrhage from a number of experts across the United States. They really say that we should be looking to adequately perfuse and achieve euvolemia and so forth. And the reason for that is, one, because children have high rates of traumatic brain injury and polytrauma, so they're very likely to have traumatic brain injury even when they have hemorrhagic trauma. And the second is that, as we said, with children, blood pressure, hypotension is a late sign. It's actually a peri-arrest condition in hemorrhagic shock, so we don't really want to keep children in that state for very long. So permissive hypotension is not something that we do routinely for children. Now there's always a nuance. A child, a pediatric patient, is from like 1 day old to 18 years old. So there's a marked difference in physiology and anatomy here. And so while this may not be appropriate for a 3-year-old, 5-year-old, 10-year-old, this may be a very appropriate strategy for an adolescent with a penetrating gunshot wound, for example. So I just want you to consider that as a nuance. Balanced resuscitation. This is giving back what they have lost. The definitions for massive transfusion are all over the place. Probably the most consistent and scientifically robust for pediatrics is more than 40 mils per kilo of all products over 24 hours. That's what is used in all the literature now. But that doesn't help you in the moment to know how much over 24 hours a patient has lost or how much you're going to need. That's really not helping you decide whether you need to activate your massive transfusion or massive hemorrhage protocol. So what we need is a critical activation threshold. And that critical activation threshold is found to be about 3 units within an hour for an adult, or an adolescent, for example, you could apply that to, or more than 20 mils per kilo of red cells within the first hour. And it makes it very nice and simple for those of us who like things simple, 20 mils per kilo of crystalloid, 20 mils per kilo of blood, and then move to your massive hemorrhage protocol. And that is derived from the Trauma Quality Improvement Performance database that exists within North America. Whole blood transfusion. So if we ultimately want to provide what we've lost, this is the way to do it. There is limited but emerging evidence and increasing use in children. I'm going to talk a little bit more about that. But right now we're using ratio-based for the most part. Empiric ratio-based red cells, plasma, platelets, once they've stabilized somewhat, moving to a goal-directed approach, trying to emulate whole blood. So the ratios are felt to be around 2 to 1 to 0.5, or a 20-10 to 5, which is what you saw in that Broslow-based transfusion guide. There are studies conflicting around high plasma or plasma deficits and platelet deficits and different ratios, and there is a pediatric study that did show a mortality benefit when using a 1-to-1. But we don't have a proper trial. We don't have a prospective randomized control trial in pediatrics to really tell us this. And ideally, if we're transfusing patients with this amount of products, we're doing it with viscoelastic hemostatic assays, which are things like ROTEM and TEG, which are point-of-care coagulation tests that are much more nimble and tell you what's happening in the moment to allow you to guide. This is something that is much more routinely used in the United States. I can tell you that a few centers in Canada are using it in adults, but there are no pediatric trauma centers that use it in Canada right now. How do you achieve a balanced transfusion? You improve the team's awareness with massive hemorrhage protocols, so people are aware of their protocol and what products are going to come. You improve vascular access. So very important to recognize that you need good vascular access in order to get all this product into a patient. So you need to have large, short vascular access. That's why peripheral IVs, antecubital peripheral IVs, the largest that you can get, are good. In a child who requires an intraosseous, there's a little bit of a rule of thumb in my mind, is that if a child requires 1 IO, they need 2 IOs. And if you simply need an IO to achieve access, certainly start where you're most likely to be successful, the proximal tibia. If you need to transfuse a patient, though, that's not a great site, and you may consider either the distal femur or even better, the proximal humerus, where flow rates are higher. You want to reduce delays in product availability, and some of the ways that you can do that are bedside emergency blood refrigeration. Some centers have it, some don't. Thawed immediate release plasma, again, our center, for example, does not do that. Shelf-stable freeze-dried plasma. I don't know if that's available in Colombia. In Canada, that is reserved for the military. Rapid plasma thawing devices and procedures, or low titer group whole blood. So that's what I'm going to move to now, which is whole blood. 1 unit contains your red cells, plasma, platelets, and cryo. In adults, it's considered the resuscitation fluid of choice in trauma, showing survival benefit in both combat and civilian settings. Benefits are that it's rapid, it provides a balanced resuscitation, the platelets are stored at 4 degrees, less potential for contamination, theoretically more hemostasis, and there are a few additives and donor exposures. And really, the main benefit is this simply logistic. You have 1 unit that you're giving as opposed to multiple bags that you're trying to balance. There are about 11 centers in the United States right now in pediatrics that are using whole blood, and there are about seven pediatric studies to date, including a systematic review, looking at this in pre-hospital and hospital settings. They are small sample sizes and single-center cohorts, and there is a statement from experts that we really do need multi-center randomized controlled trials before we roll this into practice for everybody. But what these studies have shown is safety. So thus far, there has been an absence of hemolysis and transfusion reactions and a comparable risk of organ failure. And the benefits being faster resolution of shock and coagulopathy, lower overall transfusion volumes, and 1 study showed an independent association with survival in the massively transfused group. So more to come on whole blood, but it's certainly something that we're thinking about. I showed you that lethal triad of trauma before. One of the new things that's happened maybe in the last 5 years or so is really considering the role of calcium and changing this triangle or triad into the lethal diamond, and recognizing that hypocalcemia is not simply from the citrate that we're giving when we're transfusing, but a certain proportion of trauma patients, including children, present hypocalcemic already as part of their acute traumatic coagulopathy. And calcium itself has inherent sort of interactions with acidosis and hypothermia and coagulopathy. And so this is really something that's been focused on in terms of the massive hemorrhage protocols about empirically delivering calcium, frequently checking calcium, and ensuring that it's not being forgotten as we massively transfuse our children. And then lastly, stop it. Definitively stop that bleed in the OR or the IR. In children, it's, we can talk a lot about ratios, we can talk a lot about what this, what, but really it's not just what, but how do we do it? We know that children are more predisposed to hypothermia. They have higher rates of hyperkalemia and higher rates of hypocalcemia. So there's a little infographic that was developed as part of the toolkit in terms of how you would transfuse blood in stable patients versus an unstable child, depending upon the access that they have. So certainly if you can use a rapid transfuser, absolutely. If you're unable to use a rapid transfuser, certain fluid warmers, fluid warming devices, pressure bags, or push-pull will be what you need to use. A quick word about tranexamic acid, TXA. What is it and why do we talk about it so much? It inhibits fibrinolysis, so it's not actually preventing clots, but it's forming clots is preventing the breakdown of existing clots. And it has been shown to reduce blood loss and transfusion requirements in the operative setting, and other settings, and trauma as well. And it's felt it also might mitigate some of the systemic anti-inflammatory response to massive hemorrhage and may contribute in that way to survival as well. In 2010, I think, 2010 or 2011, the CRASH-2 trial was published, which was the global randomized control trial that showed a survival benefit with tranexamic acid and sort of kick-started this massive amount of research and interest and use of TXA in our trauma patients. What we can say now, 2024, is that it's well studied within the adult trauma literature, and there's a clear benefit if given within 3 hours from injury, but there's still unclear evidence in pediatric trauma. And when you review all of the pediatric studies, there's very inconsistent results. Some are positive, some are negative. What we do have is one prospective trial, which is the subset of the MATIC trial, which is massive transfusion in children, an observational cohort from multi-centers that did show a survival benefit with antifibrinolytics in the setting of trauma and surgical bleeding. So our recommendation now is actually not that different than it was 10 years ago, is that empiric TXA may be considered for pediatric trauma if less than 3 hours from injury. In practice, children with life-threatening bleeding that require transfusion regardless of age, there's increasing evidence of benefit, and it can be used within 3 hours of injury. The dose is empirically translated from the operating room to about 15 to 30 mils per kilo, now with pharmacokinetic studies, with a max dose of 2 grams. In adults, they've moved away from an infusion and are simply giving it as a bolus dose. That's not been studied in pediatrics, and an infusion is recommended for ongoing hemorrhage. We do require high-quality evidence, though, to clarify the indications, measure survival, meaningful outcomes, and explore the optimal dosing and safety that is urgently needed. And you might say, well, it's pretty safe. Why not just give it? Why do you have to research it? The thing is that everything with low-value care or what have you is that vascular access is precious in these patients. We certainly don't want to be tying it up with infusions that we don't need, for example. So I would say for the most part in children with life-threatening bleeding, geographic global patterns exist, but many children are getting TXA at this point. And it has been identified, in addition to prompt identification of treatment of shock, defining the common data elements around this topic, as the 3 areas that require clinical trials would be whole blood, tranexamic acid, and the use of viscoelastic monitoring. And see, these are the research priorities from the clinical consensus and research consensus on pediatric traumatic hemorrhagic shock. Lastly, we'll just talk a little bit about pre-hospital transfusion in pediatric trauma. This refers to any blood products that are given prior to a patient actually getting into the hospital setting. We know in adults that for every 1 minute delay, there's a 5% increase in mortality for adults. And we actually know from MADIC that the mortality among injured children with life-threatening bleeding is about 2 to 3 times higher than in adults. And this study was a statewide, Pennsylvania statewide registry analysis of children who received pre-hospital products. And is the first one to show survival. And basically what they found was that for every unit of red cells transfused in the pre-hospital setting, a child had twice the increased odds of survival, with a number needed to treat to save 1 life of 5. And so there's quite a significant emphasis on this. So certainly when you go to trauma conferences, there's a lot of talking about pre-hospital transfusion, and this could be through local EMS units up to critical care units, which are doing this routinely. So in summary, for a bleeding patient, control hemorrhage rapidly. Stop the bleed. That's your first priority. Identify compensated shock when possible and treat that rapidly and aggressively. Utilize a balanced resuscitation and damage control resuscitation principles. They are applicable to children. And I would say the most important thing is to know your protocol and to optimize and practice that protocol through automation that allows you to, some of these things to happen without you having to think about them, multidisciplinary simulation, and quality assurance through audits and metrics and so forth. And then definitive source control. And this is particularly important in children. Do not delay a patient getting to definitive source control to stabilize them. These patients will not be stabilized. They need to have that. And this is a phenomena that's quite common in pediatrics. We're a little less hesitant, or we're more hesitant to rapidly and aggressively treat them as we would in adults. And I think that's very, very important, is to not delay. And that's it. So with that, I'll end there. Thank you very much again for your time. And happy to take any questions. Thank you.